Welcome to the Healing Pain Podcast with Dr. Joe Tatta. Each week, we interview top experts in physical therapy, pain science, and integrative pain care. You'll learn the most up-to-date information for treating and reversing persistent pain. This podcast is for educational purposes only and not intended to be used as personalized medical advice. And now, here's your host, Dr. Joe Tatta.
Hey there, friends. Thanks for joining me this week and welcome back to the show. This week, we are discussing the impact of physical therapy on long-term opioid use for patients undergoing a total knee replacement. My expert guest this week is Professor Deepak Kumar. He's an assistant professor in the Department of Physical Therapy and Athletic Training at Boston University and section of rheumatology at Boston University School of Medicine. He directs the Movement and Applied Imaging Lab at Boston University. The goal of Dr. Kumar's research is to improve quality and quantity of movement during everyday life in people with knee osteoarthritis to reduce pain, improve physical function, and maintain joint health. On today's episode, we're going to review the findings of Professor Kumar's study called The Association of Physical Therapy Interventions for People with Long-Term Opioid Use After a Total Knee Replacement. You can find that article in the October 2021 edition of the Journal of the American Medical Association. This podcast obviously has implications for people with chronic pain, also important information here for opioid use, and of course, the positive impact that physical therapy can have on people's lives living with chronic pain. Without further ado, let's begin and let's meet Professor Deepak Kumar. Hi there, Deepak. Thanks for joining the show this week. It's nice to have you here.
Hi, Joe. Thank you for having me. Happy to be here.
I'm excited to talk with you about this topic. I think as physical therapists, this is a really important information to be us talk about, obviously opioids and how it can impact certain populations of people living with chronic pain. We're going to focus in on a study that you conducted, an investigation. I want to point everyone toward that so they can read it and look at it. It is in the Journal of the American Medical Association, October 2021, and it's called The Association of Physical Therapy Interventions with Long-Term Opioid Use After a Total Knee Replacement. Important study. I read the whole study. It's full of information for physical therapists, obviously orthopedic surgeons, because they're highly involved in the care process, and of course for people living with pain. Tell us why you chose to study this topic.
Yeah, thank you for that question. My research practice, if I can say that, is primarily in people with knee osteoarthritis. And if you think about the spectrum of the disease, then people who undergo total knee replacement are sort of the people who are sort of at the end stage, as we call it, of this disease process. As we cited in the paper, the number of total knee replacement surgeries is growing pretty rapidly. I think the number is expected to exponentially increase over the next few years to like over 3 million a year by 2030. And despite the fact that it is generally a very successful surgery, depending on which study you cite, like 1 in 5 or 1 in 4 individuals continue to have persistent pain after the surgery. So given the large number of surgeries that happen, this number is not trivial. So there is obviously a clear failure of strategies for pain management in these individuals who continue to have pain after surgery. And then the other aspect is that not insignificant number of individuals who undergo the surgery become long-term opioid users. So depending on whether a person has used opioids before the surgery or hasn't, opioid experienced or naive as we're calling them here, anywhere from like 3% to 50% of these individuals can go on to become long-term opioid users. So again, we know that opioids are not the best way to manage pain in these individuals. In fact, it can make the pain worse in some individuals. So again, there's a clear failure of strategies to manage pain. And we know from a lot of prior studies that physical therapy interventions can be very effective at managing pain. So we wanted to study whether physical therapy interventions provided before surgery or after surgery can reduce the likelihood of a person becoming a long-term opioid user. So that's why we did the study.
Lots of great statistics you have there to open up with. I think there are some really great stats that people would be interested in. I just want to make sure I understood everything that you said clearly. The first thing that you mentioned is even though people have a knee replacement, so the joint is obviously replaced completely, they still go on to have pain. Can you review that stat with us? I think it's a really important stat that people should be aware of.
Yeah, as I was saying that depending on which study you look at, but I think the generally accepted number in the field is that 1 in 5 individuals continue to have what is called as persistent knee pain, which is pain specifically defined as a worsening of previous pain or a presence of a new pain after surgery. So for at least 3 or more months after surgery. So again, 1 in 5 individuals is not a small number given the large number of these surgeries.
Certainly, that's certainly true. And it might be a little confusing to people who have either had a knee replacement or people who are considering a knee replacement. And this could be a whole another show just in and of itself. But maybe just give us like 1 or 2 points of how, if someone had their entire joint replaced, so they underwent surgery, had the entire joint replaced, how can they continue to have pain?
Yeah, that's a great question. And as you sort of hinted at, this might be a whole new can of worms that we can open here. But to be honest, our understanding of why people experience pain when they have knee osteoarthritis is okay, it's not great. So the actual damage to the joint is not always the only reason for people to experience pain, as surprising as that might be to people. So it's not uncommon for people to think that, osteoarthritis means the cartilage is wearing away. That means the bones are touching or coming in contact and that's causing pain. And we know from a lot of studies that that's not always the case. So the source of pain in people with knee osteoarthritis can partially be the damage to the joint tissues. Cartilage damage itself does not cause pain because there are no pain sensing fibers in the cartilage, but the damage to the bone around the joint, damage to the covering of the joint, which is called the synovium, damage to the muscles can cause pain. But in individuals who have chronic pain, like people who have knee osteoarthritis, the pain can mostly be coming from an abnormality in how pain is processed by the brain. I want to be careful how I say this because nobody likes to be told that the pain is in their brain, but technically we call this sensitization, pain sensitization, and I'm sure this has come up many times on your podcast earlier, I'm sure. But a large number of people with knee osteoarthritis and other conditions where people have chronic pain, like low back pain, fibromyalgia, the way body processes the pain information goes haywire, and people can perceive pain when pain is not helping the body in any way. So if you think about acute pain, which is like if you're walking and you hit your foot against the sidewalk, so you stub your toe, that time the pain you feel is the pain that is actually helpful to you, that you understand that you had an injury, you need to protect that part of your body. But in individuals with chronic pain, sometimes they get these pain signals or they perceive pain when there's not really any helpful information carried in these signals, if that makes sense. So we know that this sensitization can persist after knee replacement surgery. So people can continue to experience sensitization. That can be one reason why they continue to experience pain, but we don't know much more than that about why people continue to experience pain after total knee replacement, unfortunately.
Right. But still lots of good take homes in there. So obviously kind of the main ones are that you may have osteoarthritis, but joint damage is only a part of the equation of what's contributing to your pain. There are other lifestyle factors and affective or psychosocial factors that impact how pain is processed throughout your body. Obviously, the nervous system is the one place that we talk about the most, or the brain is the one place that we talk about the most. Your cohort was quite large in this study. Why don't you go through some of the details, some of the findings about what you found in the study?
Sure. Yeah, we used an insurance claims database. So if people aren't familiar with that, that means that we purchased access to insurance information for a large number of people in the country through through like a third-party service. So one thing to know is that in these data, we only have information on insurance claims. So that means that we do not have information on how advanced somebody's osteoarthritis was, how severe their pain was. Like, we don't have that actual clinical information. We only have information on claims that were filed on their behalf. Having said that, we looked at people who underwent total knee replacement between 2001 and 2016. So we started with over 2.5 million people who underwent surgery in that time period. And once we applied our study criteria, we ended up with a cohort of about 67,000 individuals who were eligible to be studied in this analysis. As I was mentioning earlier, whether you have used opioids before or not can be a strong predictor of whether you'll use opioids in the future. So we wanted to separate those two groups out. So we took the 67,000 people and we divided them into two groups. So people who had used opioids in the 12 months period before surgery and people who had not. So we had about 29,000 people in the opioid experienced group and about 38,000 people in the opioid naive group. And then we looked at our main question, which is, do physical therapy interventions before surgery or after surgery are associated with reduced likelihood of long-term opioid use? And long-term opioid use was defined as 90 or more days of opioid prescriptions that were filled by the patients. For physical therapy before surgery, we looked at 90 days before surgery. For physical therapy after surgery, we looked at 90 days after surgery. One difference was that for before surgery, we looked at physical therapy interventions provided in an outpatient setting or inpatient setting. But for after surgery, we only looked at physical therapy interventions provided in outpatient settings because almost everybody gets at least like 1 or 2 days of physical therapy immediately after surgery. So we wanted to focus on the outpatient physical therapy care after surgery, just to be clear over there. And then we also wanted to see whether there's specific attributes of physical therapy interventions after surgery that might be more associated with reduced likelihood of chronic opioid use. For example, we looked at how quickly after surgery did somebody see an outpatient physical therapist. We also looked at number of outpatient physical therapy sessions. And then we also looked at the type of physical therapy interventions, and we classified them into active, which we consider as interventions where the patient is actually participating in the intervention. So these are usually exercise, teaching them how to walk differently, teaching them how to self-manage their symptoms, etc. And passive interventions where, if you think about it, the patient is not really participating in the intervention. So things like TENS or hot pack or cold pack, things like that, modalities. And you wanted to see if those two types of interventions had differing effects on the likelihood of long-term opioid use. So that's how the study was set up. And then we looked at outcome over a 1-year period, starting 90 days after surgery. And we found that both physical therapy interventions before surgery and physical therapy interventions after surgery were both associated with reduced likelihood of people using opioids long-term. And this was consistent in people who had used opioids before and who hadn't used opioids before. We also found strong effects for starting physical therapy care early after the surgery. So if you start outpatient physical therapy within 30 days of the surgery, your likelihood of using opioids long-term were much lower compared to people who start outpatient physical therapy more than 30 days after surgery. We also found some signal for a almost like a dose response effect, which means that the greater number of physical therapy sessions were associated with reduced likelihood of long-term opioid use. This was a bit inconsistent across the two groups. And the one surprising finding we had was that we did not find an association between active physical therapy interventions and opioid use in this cohort.
Deepak, I know I can say for all of our colleagues that there's a lot of good information in here for the physical therapy profession. I think they'll be excited to hear the impact of physical therapy, obviously both before, pre, and post a total knee replacement. Did anything surprise you from the study once you started to analyze the data?
Yeah, as I started to mention in the response to the last question, the last part, the finding that active physical therapy associations were not anymore likely to reduce reliance on long-term opioids was surprising to us. This is coming from the literature on people who have knee osteoarthritis in general, not specifically people who have knee replacement surgeries, but there is like decades and decades of information that exercise interventions are more effective than passive interventions for people who have knee osteoarthritis, and we know that, and it's an accepted sort of fact at this point. So we were quite surprised that that wasn't the case in this particular analysis that we did. And there's a couple of reasons why that might be, that's what we found. One reason could be that the way we defined active interventions might not be the best. We defined active interventions as 50% or more of the interventions being in the active category. Perhaps what matters is if they received any active interventions versus, a certain proportion of the intervention being active, because that 50% number, although it came from prior studies, it's still arbitrary. So perhaps future studies can look at any active interventions versus, just completely passive interventions. Another reason could be that, again, this is not well studied in people with knee replacement. And given what we know about why these people continue to experience pain, that it might be sensitization or psychosocial factors, etc., it's possible that exercise interventions by itself might not be sufficient to sort of deal with these biological processes, and something else might be needed for these individuals that is not currently provided in physical therapy interventions. For example, cognitive behavioral therapy or mindfulness, etc.
Right. Great points. Obviously, bring in the psychosocial aspects. Obviously, you probably have received some feedback from colleagues. How are you recommending that professionals, whether it's a physical therapist or another licensed health professional, how can they take this information and use it either for public health promotion or potentially in their own clinic or their own practice, or maybe even talking with a payer who may be interested in ways to manage pain more effectively?
Yeah, thanks. I think before I respond, I just want to put a caveat out there that this was not a clinical trial. So, the caveat that comes from the fact that this was an observational study applies here. But given that our effects were very consistent and strong and large, I think I'm comfortable saying that if payers and providers can ensure that people who undergo total knee replacement can get to an outpatient physical therapist within 30 days of surgery, and if they can receive some physical therapy before surgery, that might help with reducing their likelihood of having long-term opioid use in the future, if that makes sense. I think anything more than that probably would need larger, other studies, these findings to be replicated in other studies or clinical trials, but I'm fairly comfortable making that sort of statement here. Is that what you were looking for, Joe?
Yeah, it is. And, it kind of starts to take me down another path as I've read your study and we're talking here. Just to play devil's advocate, Deepak, as you know, with evidence-based medicine, people are always looking for, who is this person? Why did they do this study? Is there a conflict of interest? People might say, well, hey, this guy's a physical therapist. Obviously, he's going to find good results for physical therapy. He's biased, obviously, toward physical therapy helping people with regard to opioid misuse and opioid misuse disorder. What kind of feedback might you have for someone who is thinking those things?
Yeah, and that's a great question, and a fair question to ask. I want to disclose that this study was the work, the people who conducted the study, including myself, we were supported by funding from the National Institutes of Health, and a couple of the authors had funding from the pharmaceutical companies for work not related to this study. So the motivation for the study came about from a rheumatologist colleague of mine, Dr. Tuhina Nyoji, who's a co-author, and myself. So we sort of came up with this idea, and the findings are, really what they are. There's the data have not been sort of manipulated in any way. We're happy to make the data freely available to individuals, but Yeah, there's no conflicts of interest for any of the authors and for this study.
Yeah. And even though it's a different patient population, there have been similar studies with regard to, I believe it's low back pain and the impact of physical therapy on opioid use and misuse disorder.
That's correct. There has been work in people with low back pain where early physical therapy after an acute or emergency room visit for low back pain condition has been shown to reduce use of opioids long term. And we also have found similar findings in people who have knee osteoarthritis but are not yet ready for surgery. And we're seeing a consistent pattern there. So these findings do seem to be sort of valid in many different populations with chronic musculoskeletal pain, not just people who undergo knee replacement. That's correct.
Right. So we're seeing this pattern consistent with people with chronic low back pain. We're seeing the pattern consistent with people who are undergoing a total knee replacement and people who are seeking conservative care for knee osteoarthritis. So three key groups there. Yeah. If there's a researcher who's listening, or maybe a physical therapist who's interested in researching this topic more, what other areas, I always think of like, okay, in the center of the circle, we have opioids and knee osteoarthritis, but there are overlapping circles with this topic. What areas do you start to think of, hey, we should really start to investigate it's similar to this, but another population or another topic?
Yeah, so I think, let me first say that within this population even, I think there's unanswered questions that need to be looked at. For example, I think one very important area to further look at is, are these findings consistent across different racial and ethnic subgroups? Because there, as you might know, Joe, and as the listeners might know already, there are inequities in access to physical therapy care in racial minorities, especially in Black adults and Hispanic adults. They are referred to physical therapy less often than non-Hispanic whites. So there are some inequity issues here that need further study in terms of whether these findings hold true for different racial or ethnic subgroups. And then in terms of other populations, it would be interesting to see whether these findings are similar in other groups of individuals who undergo surgeries. For example, people who undergo total hip replacement, which is another big sort of group of people who get surgery, and that number is also going up all the time. So that's another group to look at in terms of to see whether physical therapy interventions there are similarly associated with reduced likelihood of opioid use.
Have any payers reached out to you with regard to your data, asking to access the data or to discuss the data with you?
So that's interesting because the data is from the payers, right? It's all insurance data. It's their own data. So they can look at it anytime they want. We actually had to buy their data. They actually have it. So they can look at it anytime they want, right?
That's really interesting to think about. So they have the data.
Yeah.
But the question is, are they analyzing the data the way you did?
Yeah. So, to answer your original question, none of the payers have reached out to us, but our methods are in the paper. To be honest, the methods are not super innovative or groundbreaking. It's something that has been done in many of the studies. It's fairly straightforward. It's about defining a cohort well. So again, the payers have the ability to try and replicate these findings for their sort of client population base and see if that holds true, and that can inform their policies and what they want to reimburse and when they want to reimburse.
Right. Or how many visits they'd like to reimburse for physical therapy status post total knee replacement. And your study really looks at probably around the number six visits, so to speak, is where people show the strongest benefit or show a significant benefit.
Yeah, we categorized visits into 5 or less, and then 6 to 12 or 13 or more. And we found that compared to 5 or less, the other two groups had progressively larger sort of protective effects. So at least 6 would be a starting point for people to think about, like, what's the minimum number. But I think more like going up to 10 or 12 is probably more helpful because the effect keeps getting stronger. And then we also know from other studies that generally physical therapy interventions can be cost effective when compared to, say, intra-articular injections or other invasive procedures. So that's another reason to think about using physical therapy interventions to manage pain versus some of these more invasive procedures. Also, given the fact that physical therapy interventions, generally speaking, are very available. They're available to most individuals. So yeah, that's another reason to think about them.
Physical therapy interventions are available, but wouldn't it be nice if payers took this information and said, hey, this looks like most patients with a total knee replacement need 6 visits. Let's just make a rule that every patient who receives a total knee replacement can receive 6 visits of outpatient physical therapy. No questions asked, no pre-authorization, no fighting with the insurance company, no back and forth. So obviously we take down some of the barriers that exist. Really, the barriers exist for patients, right? I mean, of course, these are barriers for us as well as providers, but the biggest barriers for the patient, right? How do we help people obviously overcome what they're experiencing? So that's really, that really jumped out to me on the page. Like, well, here's a real life application, a real life clinical application of how this information can weave its way, obviously, through the payers networks. Oftentimes there are third parties that will administer care, so to speak, or authorize care. And then obviously us as the professional and the patient trying to provide care.
Yeah, I think for us as the professional or as the providers, we probably want to think about how we can do a better job of actually getting the patients into the clinic as quickly as we can, because again, that 30-day period seems important. So I know sometimes our practices are busy and patients have to wait. So whatever we can do to sort of get them in, and that's not really my area of research. You probably know about it more than I do, but yeah.
I like that. So 6 visits within 30 days.
Yeah.
Right. That's important for people. So if you have a total knee replacement, what the data is starting to show is you'll benefit from receiving physical therapy within 30 days and probably for an average of about 6 visits at least, it looks like. I really appreciate that. Deepak, great work. I'd love for you to come back. My platform is yours. If you have any other information on the impact of PT for people with pain and obviously opioids, please come back and join us. But in the meantime, tell everyone how they can learn more about you and follow your work.
Thanks, Joe. I just want to say that I want to thank you for all that you do to disseminate, what we do as scientists to the public, because sometimes we as scientists don't do a good job of it. So thank you for helping us out. And then to learn more about what we do, I think I would invite people to visit our lab website, which I don't know. I guess you can share the link with the audience. But yeah. We are at Boston University and Boston University School of Medicine. We are a large group of researchers, interdisciplinary rheumatologists, physical therapists, engineers who work together to solve problems around managing pain in people with knee osteoarthritis. So check us out.
Right. And of course, all the information will be available on the show notes at the Integrative Pain Science Institute. That includes Professor Kumar's website address at bostonuniversity.edu. And you can also tweet out to him on social media. So it's at ProfDeepakKumar. So it's pretty easy. So it's at Prof. Deepak Kumar on Twitter, and you can reach out to him. At the end of every episode, I ask you to share this information with your friends and colleagues. Of course, if you're a physical therapist, I would love for you to hop on Instagram or Facebook and Twitter and tweet this out so we can educate the public about the impact of physical therapy and opioids for people with total knee replacements. I'm Dr. Joe Tatta. It's been a pleasure spending this time with you this week, and we'll see you next week.
Thank you for listening to the Healing Pain Podcast with Dr. Joe Tatta. To subscribe to the podcast and learn more, visit integrativepainscienceinstitute.com. That's Integrative Pain Science Institute.com. Sign up to receive weekly updates, leave a review on iTunes, and share this episode with your friends.